we recently conducted, like in 2017, we conducted a systematic review on the evidence of perioperative systemic therapy for patients who undergo resection of resectable colorectal peritoneal metastasis. And in contrast with colorectal liver metastasis, we found that there is no evidence to either support or discourage the use of perioperative systemic therapy in this setting. This lack of evidence leads to a lot of different treatment strategies across countries, institutes, and physicians. And as such, we decided to start the CAIRO6 trial in the Netherlands. The standard treatment for resectable colorectal peritoneal metastasis is cytoreductive surgery with HIPEC alone, followed by surveillance. We designed the CAIRO6 trial to assess the potential superiority of an experimental arm consisting of perioperative systemic therapy, neoadjuvant and adjuvant treatment, combined with cytoreductive surgery with HIPEC for patients with isolated resectable colorectal peritoneal metastasis. This is a randomized superiority trial with the hypothesis that 3-year overall survival in the experimental arm, so the arm with perioperative systemic therapy, is 65%, and the control arm, so the arm with cytoreductive surgery and HIPEC alone, is 50%. We need 358 patients to do this trial. So that's mainly the rationale and the design of the trial. In the Netherlands, there were some major concerns in the field about this trial. Mainly surgeons and oncologists who were involved thought that giving neoadjuvant treatment combined with bevacizumab, which is the experimental arm of the trial, would lead to an increased amount of major postoperative morbidity in surgery that is already considered morbid. Secondly, people were concerned about preoperative progression while giving neoadjuvant treatment, as colorectal peritoneal metastases are generally considered less sensitive for systemic therapy than, for example, colorectal liver metastasis. And the third main concern was that physicians in the Netherlands thought that we were unable to enroll enough patients in, for example, 5 years to complete the trial, because they thought it was too difficult to enroll patients for this trial. And that's why we designed a pilot phase, more or less similar to the pilot phase of the Foxtrot trial, which the majority of you may know, to assess the feasibility, safety of perioperative systemic therapy in this setting, and to assess the feasibility of trial accrual before proceeding to the phase 3 trial, which has overall survival as the primary outcome. So that was the main rationale for designing the pilot phase, which we present at the Congress.